Before we begin, I want to make something clear. This is not about whether deciding Richard Allen is innocent or guilty. It's not a legal analysis. This video is not an attack on anyone. It looks at the case through the lens of a qualified care worker in terms of safeguarding mental health and human welfare. After reading the appellate briefs, one overall issue stands out to me: the impact of 13 months of restricted confinement upon Richard Allen's mental health. When most people discuss this case, they often start with what the state deemed confessions. And as a care worker, I start with the person. I ask, what was their mental state? What was their environment like? What support are they getting, and what changes occurred over time? Because behaviour doesn't happen in a vacuum. People don't just wake up one day and start drinking toilet water, eating faeces, harming themselves and questioning reality. Something's happening there, and understanding that process is what matters. Richard Allen spent 13 months in highly restricted custody under a safekeeping order. A placement can be protective on paper, but it can still cause psychological harm. One thing mental health professionals have known for decades is that prolonged isolation can affect people in profound ways. The risks are well documented: depression, anxiety, sleep disturbance, memory problems, emotional dysregulation, paranoia, hallucinations, self-harm, and loss of contact with reality. The defence brief points to litigation involving Indiana prisons where prolonged solitary confinement was associated with predictable psychological deterioration, including depression, hallucinations, paranoia, self-injury, eating problems, and cognitive difficulties. And as care workers, it's not something we can ignore. According to defence filings, Allen's mental health appears to have deteriorated significantly during pre-trial confinement. The defence describes symptoms such as weight loss, self-harm, head banging, eating and smearing faeces, psychotic symptoms, paranoia, involuntary medication, being declared gravely disabled. And from a safeguarding perspective, these behaviours indicate a serious mental health crisis. As care workers, timelines matter, and the defence argues Allen's mental decline was visible prior to his incriminating statements being made that were deemed confessions in court. By the month of March, Allen was struggling psychologically. By late March, he was becoming increasingly paranoid. By early April, clinicians described him as deteriorating. In mid-April, he was engaging in self-destructive behaviours and displaying signs of psychosis. The deterioration came first, and the so-called confessions followed. The legal system asks if the statements were voluntary, but a care professional asks if the person was mentally well enough for these statements to be considered reliable. The defence pointed to a phone call Allen made to his father where he was questioning his lucidity. Later that same day, incriminating statements were made to his wife, and he subsequently appeared unable to recall doing so, and it raises questions about his mental state. Psychosis can affect judgment, perception, memory, reality testing, interpretation of events, and the sense of self, and people experiencing psychosis may sincerely believe things that are not true, and they may develop false memories and struggle to distinguish reality from internal experiences. Therefore, the mental state becomes a central part of understanding what they are saying. Should Mr. Allen have been moved? This is perhaps the biggest safeguarding question in this case. Prisoners experiencing serious mental illness are normally transferred into a treatment-focused mental health unit, rather than remaining in prolonged restricted confinement settings. At what point should treatment take priority over someone's security? If someone is psychotic and self-harming, eating faeces, and involuntarily medicated and described as gravely disabled, that's when. One thing that gets lost in a high-profile case is the human being at the centre of it, regardless of where someone stands on Allen's conviction. The records describe a person who is experiencing profound psychological distress, a person losing touch with reality and experiencing fear that he was losing his mind, a person requiring significant mental health care intervention. And as care professionals, we've got a responsibility to see that human reality. So after reading both sides of the appeal, what stands out to me is the intersection of prolonged isolation, psychological deterioration, and repeated incriminating statements. Courts decide what is legally admissible. The appellate judges will decide if the conviction stands. However, from a care professional perspective, the central question remains: what happens when a human being spends 13 months in restrictive confinement and begins to show signs of severe mental illness? How should we understand statements made during that period? These are really difficult questions, but they are worth asking.